Thank you for joining us for this portion of the Medicare Education Expo. We're going to be talking about Part A billing. You may have tuned in for one or more of our earlier sessions today, or some of the ones that are following this one. For some of you, this might be the only one that you registered for. Either way, we are so glad that you are here. Our title is Out of the Shadows, Unmasking the Mysteries of Part A Billing. Speaking of masking, I'd like to introduce myself, to give you the chance to put a face with a name and voice. I'm Aline Sigler, and this slide contains a little bit about me and my Medicare experience. Also on the line with me behind the scenes is Mary Sue Gardner. She's helping me out, adding some things to the chat, monitoring the chat. So I want to thank her for her assistance as well. A little bit about the training center of our website. That's where we post the event materials for most webinars. We do that about a week in advance. So if you want to download a copy of the slide deck, you can find it usually on our live events page. Now I said most because for this event, a copy of the presentation was emailed yesterday, and I sent it to the email that you used when you registered. If you don't see it, check your junk or your spam folder. But don't worry about it right this minute. You don't have to have it to participate. The live events page that I mentioned is also where you can find out about and register for upcoming educational events. You can find the recording of this and other live webinars also on our website in another section called Encore Presentations. So for anybody who missed the event, maybe there were more than one that you wanted to attend, but it didn't fit in your schedule, things like that. They're normally available on our website for 60 to 90 days. And you can also find them on our YouTube channel. For questions that you have related to today, you can put them in the chat. Whether you're listening live or you're listening to the encore, we hope you'll take the opportunity to give us your feedback by taking our survey. Those surveys give us insight into not only how we're doing, but also the types of education you want and need. We have a couple disclaimers and copyright notices here. You can all read. I don't want to spend a lot of time on them. Just to let you know that we're giving you the most up-to-date information that we can, and that the codes that are contained in the presentation are not created or maintained by WPS. You know anything about Medicare, you know that we love acronyms. The next 3 slides contain acronyms that were used in this presentation or that I know I'm going to be mentioning. There are so many of them and too many to try to memorize. They can get pretty wordy, some of the Medicare terms. So we use acronyms, and that's why we've included them here. We also have a wide variety of experience levels and a variety of different provider types on the line. So some of these acronyms may not be as familiar to you as some of the others. This way, having this list, you can just refer back to them as needed. The purpose of this session is to increase your knowledge of billing Part A claims so that you can do it successfully and get paid accurately. I'll start with some billing requirements. We'll transition into examining the UB-04 claim form. We'll look at ways to kind of resurrect your claims, whether they're pending, just stuck in limbo, whether they're rejected or denied, things like that. And then at the end of our session, we'll share some tips and some resources for getting even more information. So let's begin by looking at some of the things that you need to know or do before you send claims to Medicare. We want to start with the patient. Maybe this is the first time this person has come to your office or to your facility. So you need to ask for all their insurance cards to verify their benefits and eligibility. Some patients may come in with one card, some may come in with multiple cards. Some beneficiaries may not understand exactly how coordination of benefits, supplements, and Medicare Advantage work. You need to know if they have traditional Medicare or did they enroll in a Medicare Advantage plan. Open enrollment just started yesterday, so you're probably going to be seeing some patients switching coverage. Does the patient have Medicaid or a supplemental insurance? If they're being admitted, how many days are left in their benefit period? Ask the patient or their representative if they've had any stays recently that might not have been posted yet. So claims that haven't finished processing yet, maybe haven't been billed yet. Some patients might go months or years without going to the doctor, and then all of a sudden they have a lot of appointments and a lot of stays back to back. So if they've had a recent stay that hasn't posted yet, those days will need to be subtracted from their bucket of days when you're calculating how many days they have remaining. Now remember, we have hospitals, we have skilled nursing facilities, we have clinics, we have a wide variety of different people on the line today. So not everything in this presentation is going to pertain to you in your job and at your facility. It might look a little different for each of us. Another situation that you want to consider is that maybe they were in a hospital, but the patient thought that they were in observation, not admitted. So there can be some questions there as to what actually was their status within that facility. Were they using days or were they not? If the patient hasn't had any inpatient stays in the last 60 days, they might be starting a brand new benefit period. So their days are going to renew. When you check their eligibility and you check their benefits, it looks like they don't have any days left, but because more than 60 days have gone by, when they admit to your facility, they're going to be starting a new benefit period. That means their days will renew, but it also means deductibles. All these things are going to help create the picture for this patient when you get ready to bill. There are a number of different ways to check patient eligibility. We have a variety of online tools and services that are available for you. All Medicare Administrative Contractors, or MACs, have an online provider portal. It's a requirement. At WPS, ours is called the SecureNet Access Portal, or, of course, we have to have an acronym, SNAP for short. You can choose to use the CMS eligibility application called HETS, the HIPAA Eligibility Transaction System. Your facility may already have a contract and work with a third-party entity. So that might be a billing agency or a clearinghouse or a vendor, and they might have software that you use to get eligibility and benefit information. It's also very important to find out if Medicare is the primary or secondary payer. In addition to asking questions for all patients, you're going to ask them for your insurance cards. We already mentioned that. We're going to double check the beneficiary's master record to make sure that everything matches. As a Part A provider, you're required to check eligibility or ask the patient or their representative questions about other coverage. You do this upon every inpatient admission. You do it at every outpatient encounter. If the patient's coming to you for recurring services, so identical services that happen more than once in the billing cycle, you're going to do it at the start of care. And then you're going to verify if anything's changed every 90 days after that. And those are CMS rules, not WPS rules. If this is an established patient, someone you've seen before, someone that's come to your facility before, ask them if anything has changed since they last came in or were admitted. Did they or their spouse change jobs or insurances? Again, it's open enrollment time, folks, for private insurances and Medicare. If information on the patient's file is incorrect, let's say they have since retired since they came in last time, but their retirement date hasn't been added to their record, you may have to contact the Benefits Coordination and Recovery Center. They're the only ones that can update those records. For more information on how the BCRC can assist you, you can go to the CMS website. And what I recommend is just going right up to that search bar, put BCRC in the search, and it'll bring you to a page where you can find their phone number, their hours of operation, and other information about how they can assist you. If you determine that your patient does indeed have another insurance that's responsible for the charges, send the bill to them and then turn around and send a secondary claim to Medicare that includes the payment or the denial information. This is reported on your claim with certain coding requirements based on the situation and the type of insurance it is. Some examples would be a 24 occurrence code and the date of the denial, or a value code that's specific to the type of insurance that they have and the amount they paid. Now, CMS does have some really good resources and tools that can help you learn more, and there are a couple that are listed on the resource slides. If you've downloaded and looked at the slide deck, towards the end of the presentation, there are 2 slides that contain a bunch of hyperlinks related to items that we're talking about today. You could also check out our MSP, Medicare Secondary Payer playlist on our YouTube channel for some additional education. Now, since Medicare is a federal program, we look to and we're bound by the laws and regulations that are put forth. Now, the one that I want to mention is the Administrative Simplification Compliance Act. It was implemented to improve efficiency and reduce costs that are associated with processing claims. Section 3 of that act requires that all initial claims for reimbursement under Medicare be submitted electronically. Now, with a lot of things in Medicare, if you've been around for a little while, there are exceptions. The main exception is small providers. CMS defines a small provider as an institution, facility, or group of providers with fewer than 25 full-time employees, or a single physician practitioner or supplier with fewer than 10 full-time employees. Now, there's other exceptions, and some of them are listed here on this slide, as you can see. Not an all-inclusive list, of course. I just wanted to mention a few of them, and then I'll tell you where you can find the rest of those exceptions the CMS has outlined for us. So another one's when there's more than one other insurance that pays before Medicare. The system has trouble seeing that Medicare is the third or tertiary payer. So we can't accept those claims on paper in those rare instances. Maybe you just don't have many Medicare patients, or you submit less than 10 Medicare claims per month on average in a calendar year. There's other situations that CMS calls unusual circumstances, I'm using air quotes, that could be evaluated on a case-by-case basis. Things like disruption of electricity or phone systems due to a storm or a disaster outside of your control. Usually those are expected to last more than 2 business days. So it's not just a simple, the lights went out because of a thunderstorm for a few minutes, usually more than 2 days. I'm in the Midwest. We have blizzards, tornadoes, hailstorms. Some of you may have hurricanes. We've all experienced flooding, other things like that that can knock out your electricity or your internet, and it disrupts your ability to transmit claims. CMS wants to take those situations into account. So just so you know that you still have options to get your claims in and your payments from Medicare. The Medicare Claims Processing Manual, which is publication 100-4, chapter 24, and again, I have that link on your resource slide, gives more information about electronic billing requirements and possible reasons where you might qualify for what we call a waiver to submit paper claims. Paper claims are necessary sometimes. We might tell you to send a hard copy claim or hard copy adjustment in certain situations. We realize the time that it takes to process those is considerably longer, so it really does benefit all of us to bill electronically whenever possible. If you don't meet any of the exceptions to file paper claims to Medicare, you do have several options to file electronically. You can download them in batches using a clearinghouse, vendor, or the free software that WPS offers, and it's called PC Ace. It's a complete self-contained software package. If you're interested in learning about it and obtaining PC Ace to submit claims directly to WPS, it is available for download on the WPS health insurance website. This is our corporate site, so it's not the Medicare section of the website. I do have a link on your resource slide. Some claims can be submitted electronically into the secure side of our portal. Remember, I called that SNAP. So you see that in that second bullet there listed submitted in SNAP. Now that's just for Part B providers who bill on a CMS 1500. There are exclusions also with that, but I did want to mention it because some of you might bill for both. For our Part B providers, our institutional providers that bill on the UB-04, you can't bill your claims in the provider portal. You are permitted to key your claims to Medicare with direct data entry or DDE, and then those claims will go directly into the fiscal intermediary standard system known as FIS. So that last bullet states entered into FIS via direct data entry. So those are your options that you have for electronic billing. So let's take a closer look at the actual billing form. I realize that most, if not all of you, submit your claims electronically, unless you meet one of those exceptions that we just talked about, or the other ones that are listed in the manual that we didn't have time for. But whichever way you do, that software or that form that you use is based off of the UB-04. Since there's no way that we can know exactly what your software looks like, we're going to look at the elements of the actual form itself. They translate to fields that you use when you're transmitting or entering claims electronically. So a little bit of background. The CMS 1450, which is also known as the UB-04, is a uniform institutional provider bill suitable for use in billing multiple payers. The National Uniform Billing Committee, the NUBC, is responsible for the design and the printing of the form. Because it serves many payers, not just Medicare, not all fields are used or required by Medicare. Some might only be necessary if the situation or the bill type, which equates to the facility type, requires it. We're going to take a look at the different boxes, the fields. We call them form locators. And again, not all of them are for Medicare. So I have skipped some of them on the upcoming slides. So when you look through that and you're like, whoa, this girl doesn't know how to count. I do. I just left off the ones that Medicare doesn't use, aren't required. Some of them are self-explanatory. Some require just a little bit more detail. So we'll do that when it's warranted. You know, in my opinion, I felt like I needed to say a little bit more about some of these things. I have a screenshot here of the form, and I know it's too small to read. I just wanted to give you an idea of what it looks like. Again, we have some brand new people on our call today, and so they may not have actually seen one of these yet. So the fields are numbered, and we're going to be going from left to right and down the page. So starting with form locator 1, this is the billing provider information and includes the name, the address, and the 9-digit zip code and phone number. If you read in the manual, it also mentions fax number. You can add your fax number if you still use one regularly and you want to include it, you can. But I think that's kind of maybe an outdated thing right now. For form locators 3A and B, this is the patient control number and the medical record numbers. These aren't used by Medicare. This is for your internal use. We realize you may not register your patients using their Medicare beneficiary identifier, excuse me. And so these fields are for those things. Also, other insurances may use those numbers. Form locator 4 is the type of bill, and we'll talk a little bit more about that in just a moment. We also have the federal tax number for your facility. Form locator 6 is the statement covers period or the from and through dates for the claim. Form locator 8 is the patient's name, and you should enter it exactly like it's shown on their Medicare card or what you see in the common working file. I mentioned the patient's master record. This is their master record with Social Security. Some of you may be from small towns like I am. A man named Bunn comes in all the time for physical therapy, but his name is actually listed as Bernard. He isn't fond of his name, but if that's what is his official name, that's what you need to use on your claim. If Betty is actually Elizabeth or vice versa, use what the Medicare card and Social Security show. To do otherwise is possibly going to cause errors and hold up your claim. So just a little hint there. Form locator 9 is the patient's address and contact details. Pretty self-explanatory. So let's talk a little bit more about the type of bill. Officially, it has 4 digits, with the first one being a 0, and that's kind of implied. You're not going to add that, change that. There's nothing else at this time that it could be. So we're going to discuss the 3 digits that you are responsible for populating. The first indicates the type of facility. So for example, 1 indicates a hospital, 2 indicates a skilled nursing facility, 7 it indicates a clinic. The second digit specifies the type of care. Some examples of this are 1 for inpatient Part A, 2 inpatient but Part B only, a 3 indicates an outpatient status, 5 for outpatient critical access hospitals, or an 8 in this position indicates a swing bed. The third digit is of the type of bill, tells us the frequency or where the patient is in their stay. 0 indicates a no pay bill. This tells the system that you're not expecting reimbursement from Medicare on this claim. A 1 in the third position indicates the claims billed from admission through discharge. The entire stay is on one claim. A 2 is the first claim in a continuing stay. A 3 is also a continuing stay, but it's not the first claim and it's not the last claim. A bill type that ends in a 4 indicates that it's a discharge claim. I also want to talk a little bit more about the statement covers period, or the from and through dates of the billing period. If this is the patient's first bill, the from date and the admission date will be the same if it's an inpatient Part A claim. If it's a continuing claim, the from date will be the day after the through date on the prior bill. The through date will be the last day of the billing period, the patient's date of discharge, or their date of death, whichever is the case for your claim. Moving on to the next set of form locators. Form locator 10 is the patient's date of birth. Then we have the patient's sex, the admission date, the type of visit. Form locator 15 is the point of origin, or you might hear this called the source of admission. We also have form locator 17, which is very important. That's the discharge status code. And then fields 18 through 28 are for what we call condition codes. I'll share a little bit more about those last two. The discharge status code tells us the status of the patient as of the through date on the claim. This is either the end of the billing cycle or the discharge from the facility. And this tells the billing system where the patient went, and it helps to also properly track the patient's benefit periods. Not applying the correct discharge code can cause a lot of issues. Some of the examples that you see here, I just wanted to list a few, it can cause improper payments. And yes, an underpayment is still an error. If you code the incorrect discharge status, you might be not receiving as much reimbursement on your claim as you're entitled to. And CMS and Medicare still views that as an error. We don't want that to happen. Issues with claims processing can happen. It can delay payment to other facilities. Let's say, I'm just going to use skilled nursing facilities as an example. If you don't discharge the patient when they go to another facility type, it can impact future stays. It could even report a date of death to Social Security if you accidentally key a 20, a 20, or patient is deceased instead of a 02, which means discharging to a hospital. So you want to be careful with your discharge status codes and use them accurately. Next, I want to pause and discuss condition codes. They identify events that are related to the bill. They give the system more information about the patient's stay. I have a couple examples listed here, and you might see these on a regular basis. We have 04, that acknowledges that the patient is enrolled in a Medicare Advantage plan. For inpatient stays, you will bill the charges to the patient's managed care for payment, but you're also going to send what we call an encounter claim to original Medicare to utilize their days and keep track of their benefit period. 07 tells us that yes, this patient has elected their hospice benefit. However, this claim is not related to that terminal diagnosis. A 20 indicates that the patient requested billing for a Medicare determination. We call these demand bills. In these instances, the facility has notified the patient or their representative that they don't qualify for a Medicare level of care, but the patient disagrees and wants Medicare to decide. They have that right. 21 condition code, that's used when you're billing for a denial notice, when the patient is at a non-covered level of care, or if you're billing for excluded services that Medicare doesn't pay for, but a supplemental insurance might. Some of those situations. And of course, there's way more than this, but I just wanted to share some examples that you might encounter on your billing journey. Moving on to form locators 31 to 45. 31 to 34 are for occurrence codes and dates. 35 and 36 are for occurrence span codes and dates. 39 through 41 are where you're going to put your value codes and amounts. Now we get into the middle portion of the form where the charges will be listed. 42 is for revenue codes. 43 is the revenue code description, or it could be the investigational device exemption number or the national drug code. Those are situational. Form locator 44 is where the HCPCS, accommodation rates, or HIPS rate codes will go. Some of those might not sound familiar to you because they might not be ones that your facility or your office uses. And form locator 45 is for the line item date of service. So as we explore a few of these in greater detail, let's look at occurrence codes. They indicate when a specific action happened. So it's a 2-digit code that identifies an event or an action, and it includes the date of that event or action. Examples of this might be 11, which indicates the date or the onset of the symptoms. That's used on outpatient rehabilitation services, among others. Another one that you might see or use often is a 22, which is the date that active care ended. So this signifies the patient's last day of skilled care. Very, very, very important in the skilled nursing facility realm. I mentioned 24. That's the date the primary insurance denied, and a 32 is the date that the ABN was given to the patient, if that's applicable in your situation. Similarly are the occurrence span codes. They also identify a specific action or event, but it has a beginning and an ending associated with it. Examples include the qualifying hospital stay, that 3 midnight stay for our skilled nursing facilities. They're indicated with a 70 occurrence span. Another one that is pretty common is a 74. That specifies a non-covered level of care or dates when the patient was on a leave of absence. Value codes indicate a specific action, and they have an amount associated with them. It's also a 2-digit code identifying the action and a quantity or an amount or dollars and cents. Some examples of value codes are the 09 for the coinsurance amount that's applied to the claim, an A0, which is used by ambulances, and that indicates the zip code for the point of pickup. Another one that you might see often is when Medicare is the secondary payer. There's a code indicating the type of insurance, such as a 12 for working aged, or a 43 for disability, or a 15 for workers' compensation, etc. And then there's a dollar amount paid by the insurance, and the system uses that to calculate Medicare's secondary payment. We have 3 more form locators in the charges section. We have 46 for the service units, 47 for the total charges, and 48 for the non-covered charges. Then we start to capture payer information. Form locator 50 is the payer identification, 51 the ID that goes along with that health plan, and 52 indicates if release of information is on file. 54, prior payments. This is required when the indicated payer has paid an amount towards this bill. Units of service is something I want to talk about because it can be a few different things. It's the number of times a service or procedure was performed according to the description for the HCPCS code. This could be 1 unit per encounter. I'm thinking of things like therapy evaluations or certain codes that are reported in 15-minute increments. And so in that case, I'm thinking of some therapy services. 15 minutes equals 1 unit. This could also be drugs that have directions for a specific amount that equals 1 unit of service. It could be the number of room and board or accommodation days. If your patient was out of the facility, then this is also the number of leave of absence days. For skilled nursing facilities, this could be the number of days covered by a certain assessment period. Correct coding according to the regulations is necessary for proper reimbursement. If something's paid according to the number of units and you use the wrong number of units, your reimbursement is going to be askew as well. All right, form locator 56. This is the billing provider's NPI. And then we go to 58, which is the name of the individual under whose name the insurance benefits are carried. Then we have 59, which is the patient's relationship to the insured. Some of our primary insurances aren't through our patient, but are through our patient's spouse, parent, responsible party, etc. Several of the next group here that we have are situational. So we have 60, insured's unique ID, the insurance group name, the insurance group number. A lot of these are situational and only if they're known. Form locator 63, last one listed here, is the treatment authorization code. Again, remember, this form is not just for Medicare use. Moving right along here, we have form locator 64, which is the document control number, DCN, or the internal control number that's assigned to the original bill. 65, the employer name of the insured. Then we go into the next section on the form, which is for diagnosis codes. Form locator 66 is diagnosis code qualifier. So that indicates which version of ICD you're using. We should all be using ICD-10, but it still is required. Now, this is a field that might be one of the ones that your vendor is automatically filling for you on your claims, might not be one you even knew existed. Again, we're looking at the paper form because everything on that form translates to the electronic version. 67 is the principal diagnosis code, other diagnoses, and the present on admission indicators. Not required for every type of facility. 69 is the admitting diagnosis, and form locator 70 is the patient reason for visit codes. You're going to add the ICD-10 code for the principal diagnosis. This is the condition that's established to be chiefly responsible for this admission. You also want to code the other conditions which coexist or develop during the patient's stay. Medicare beneficiaries can have multiple comorbidities, and they should all be captured on the claim depending on the situation. All right, last set here. I'm going to take a drink real quick. Excuse me. Form Locator 74 is the principal and other procedure codes and dates. The next four are situational. So we have the attending provider name and identifiers, operating physician, and other providers' names and identifiers, depending on the situation. Form Locator 80 is where you're going to enter any remarks that are needed to give more information that's not shown elsewhere on the bill, but is necessary for proper payment. There are circumstances where remarks are required for specific claims processing or adjustments. Sometimes we tell you exactly what and how to put in remarks. I'm thinking of adjustments with the D9 condition code. We require remarks to let us know why you're adjusting this previously processed claim. I'm also thinking back to Part A to B billing. There were certain items that had to be in remarks in a certain way. Some go on the first line, some go on the second line. So when you're looking at those instructions or those processes on our website, pay attention to that. So I hope reviewing that UB-04 claim like that was helpful for you. Like I said, depending on how your vendor, if you use one, has customized your software, some of those items might be added behind the scenes without you even knowing it. Another important part of Part A billing is following up on claims that you've already sent. We recommend that you check your claims regularly, and regularly can mean different things to different providers. Preferably, you're checking them at least once a week, maybe daily even, depending on the volume of claims that you bill and how many you have in the system at any given time. There are a few different ways that you can check claim status, and it's your preference here. You can do that in direct data entry through use of the claim summary or the claim count summary. If you're a registered user of our portal, SNAP, you can get claim status there, or we have our interactive voice response phone line, our IVR. For some billing transactions, you might need to take additional action after you've submitted the claim. And sometimes there are deadlines associated with those actions. So the goal is to keep those claims moving all the way to your remittance advice, hopefully in a paid status. The sooner you realize that there's an issue by checking your claims, the sooner you can get it updated or corrected and send it on its way, right? So that's our goal. So let's talk about what to do if you have claims that are pending. You build them, they're in the system, but they don't seem to be progressing. You got to kind of put on your Inspector Clouseau hat and figure out why. If the claim has a reason code, view the narrative, the description of that code. See if it gives you an idea of what can help send it on its way. Some claims are what we call RTP'd, or return to provider, because they have missing, incorrect, or incomplete information. This is status location TB9997. You may or may not have heard that. Claims in a T status. Those are the ones, if you have direct data entry, that you can go in and correct and update. You just have to do a little investigation to see what it needs. Claims may also be pending for medical review, additional documentation requests, ADRs. They have deadlines attached to them. And that's part of the reason that I recommend that you check your claims and check them often so that you can stay on top of things and take action as soon as possible. Claims that are, or lines even, that are unprocessed, processed but unpaid. They might be rejected, meaning that they have a technical or billing error and were not paid. In these cases, you have to also determine the reason why before you can decide how to proceed. You're going to view those reason codes and its description, and then depending on what's rejected and why, take a look at your billing and take a look at your medical records. Was there an error that's easily fixed? Depending on the situation, you could either send a new claim or adjust the prior claim. And then finally, you might see claims that were denied, meaning they were unpaid for reasons due to medical necessity or some coverage criteria not being met. Denials are more clinical in nature. After you know what the denial code is telling you, look at your bill and your documentation. If you disagree with the initial claim determination, utilize your appeal rights, which also, by the way, have time limits associated with them. Show us where we missed it in the medical records that you sent. Tell us why it was medically necessary for this patient on this day to have this test or procedure or whatever the case may be. I'd also like to share a few quick reminders that can hopefully make things go more smoothly for you. I mentioned a couple of these already, but they do bear repeating. These are just things that I've learned along the way or heard from collaborating with other business units at WPS. Number one, and I will get on my soapbox, I will shout this from the mountaintop, use our self-service tools. From SNAP to the reason remark code lookup, to the prior authorization status search, to the LCD and article lookup, date calculators, everything in between. We are continuously looking at and working on ways to make things faster and more efficient for you. Use those self-service tools whenever possible. Number two, if you need to or you're required to send a hard copy claim, only use the official UB-04 claim form from the NUBC. Now you can buy copies at different suppliers, but make sure it's the initial ones. Photocopies or even downloaded and printed copies may not work for automated readers that scan the claims into the system. And that's just going to further hold up your processing of your claim. Number three, we already talked about this, but if Red, Doc, or Shorty come in for services, make sure you verify how their name is listed on Common Working File and their Medicare card. And that's how you should have it on your claim. Number four, along the same lines, if the primary insurance is listed as Blue Cross and Blue Shield, don't enter it on your claim as BCBS. I know we love acronyms, but sometimes they're not appropriate. As humans, we know that BCBS is Blue Cross and Blue Shield. It's the same thing, but the computer's programmed to read it verbatim, and it can't infer what you mean. It only knows what you have. When adding diagnosis codes to your claim, Be sure you place them in the diagnosis code fields and not just the PRV, patient reason for visit field. You run the risk of the automated edits not seeing the diagnosis code and the service being denied. This is especially important for items that are covered based on diagnosis, things that are linked to our local and national coverage determinations. The system is looking for a specific diagnosis code. You have it on your claim. It's in the PRV field. Make sure it's in the diagnosis code fields also. Just trying to help you out here. As always, I like to give you resources where you can find out some more about the things that we've talked about. I've mentioned a lot of these briefly, so you can have them here. If you download a copy of the slide deck, you have all these links. As a reminder, if you were a little late joining, the slides were sent to everyone who registered for the class. Unless you registered at the last minute and I didn't get that out to you, you can request it from the email that we have coming up here. If you don't have it, you don't see it, it's not in your junk or your spam. Now we're running short on time here. During registration, we did ask you what one question are you hoping to have answered during this webinar? And we did get quite a few great questions, so I want to thank you for that. If you didn't have a question, many of you said, I'm not sure, none, everything, I'm just here to learn as much as I can. Those are perfectly acceptable responses as well. We do have various levels of experience on the line, and sometimes seeing other people's questions is also helpful. So I might be able to get one or two done here. If I don't get through all of these questions, which I know I'm not going to, I will send them out with the answers to everyone on the call today. Christine asked, please explain the difference between rejected and denied. And we went over this. Rejected means the claim has a technical or a billing error, and denied means there's some question of medical necessity or coverage criteria not being met. Next question came from Sherry. Method 2 CAH, Critical Access Hospital billing requirements for rendering providers on a UB. And Critical Access Hospital Method 2 claims have to contain an attending or rendering physician's or non-physician practitioner's NPI, last name, and first name. If the rendering provider is different from the one at the claim level, you have to report the rendering NPI at the line level. The rendering provider must have their billing rights reassigned to the Critical Access Hospital, and that provider must be properly enrolled in the Provider Enrollment Chain and Ownership System, known as PACOS. Starting on July 1st of this year, a new billing edit was put in place that requires the provider to be properly linked to the Critical Access Hospital in PACOS. Failure to do so will result in the claim being rejected. All right, one more question. Next question comes from Linda. Why is there a difference in billable revenue codes for Part B medical necessity versus exhausted days? So what I think you mean by this, Linda, is that Medicare pays under Part B for a more limited set of non-physician medical and other health services when they're furnished to an inpatient of the hospital who is not entitled to benefits under Part A, has exhausted his or her Part A benefits, or receives services that are not covered under Part A. CMS says inpatient Part B services include inpatient ancillary services that do not require outpatient status and are not strictly provided in an outpatient setting. Services that require an outpatient status and are provided only in outpatient settings are not payable inpatient Part B services. And they give examples of clinic visits, emergency department visits, and observation. I'm going to have you look at 100-4, Chapter 4, Section 240.2. It has more information on inpatient Part B and what revenue codes are and are not billable on those bill types. Let's see, I'm looking over here. Here's another question real quick here from Kendra. We are a federally qualified health center, FQHC. When do we use a 777 versus a 778 type of bill? And this is for all provider types. A type of bill that ends in a 7 indicates a debit credit adjustment. You're changing something on a previously processed claim. An 8 means that you're completely wiping it out. You're canceling that claim entirely. Whatever money you got from Medicare will be returned. Unfortunately, that's all the time that I have for questions. I do have some closing remarks that are very important, contain a lot of information. So follow along with me and stay with me for a few more minutes, if you will. You're going to receive an email in a few minutes. It's going to thank you for attending. And this is going to contain a link to our survey for one thing, but also it's going to contain your contact hours. So if you need them for continuing education units, you're going to want to look at and keep that email. For those of you listening to this session as an encore, we thank you for your interest, but we don't have a way to capture your email address to know or to verify your attendance, so we aren't able to send a certificate to you, unfortunately. If you think of a question later, you have a week from today to submit a follow-up question. Send them to our same email mailbox that I mentioned earlier. Put today's date, something about Part A billing, so that they will come to me. I'd also like to invite you to join us for our Frights and Insights question and answer session happening on October 21st at 1 o'clock Central Time. I know Mary Sue did put something about this in the chat earlier. This is going to give you an exclusive opportunity to get your live questions answered. Any follow-up questions from any of our sessions today. When you register, you can submit additional questions for discussion. To register, go to our live events page. Please take a few minutes to complete a survey about this course. So important for us to know what you liked, what we could do better, and give us suggestions for future education. We're thinking about doing another session of our Medicare Education Expo. Let us know if you think that's a good idea. Maybe you have a topic that you'd like us to focus on. We'll take those into consideration. You have a few options with the survey, depending on your preference. I already mentioned there's a link coming in your thank you for attending email. You can use the link in the chat, or when you exit the webinar, you're going to be asked to go to an external site. And that external site is safe. It's the CMS Qualtrics page for the survey. And that message is going to look similar to what's on the right side of the slide here, or the right hand picture with the yellow triangle and the blue continue button. If you're listening to this session as an encore, you're going to get a box that's going to look like what you see here with the finger and the stars. That's going to be a link to that survey. Or you can scroll down to the description of the video to find the link. However you do that, let us know. Let us know if you would recommend our education to others. How likely are you to attend other events that we host? Those surveys are so important. Give us insight into how we're doing and the type of information and education that you're interested in. Just to let you know that we do look at the surveys. We take your feedback to heart. We are committed to making changes to improve your education experience. We have a couple examples here based on survey comments. On behalf of myself, Mary Sue, all of us in Provider Outreach and Education, want to thank you for your participation today in all of our Medicare Education Expo sessions and other sessions. We hope to have you join us for future events. We look forward to your survey comments, and you can now disconnect. Thanks, everybody. Have a great rest of your day.